Good afternoon, everyone. I'm Dr. Praveen, Manager, Market Access and Advocacy, SAT India. On behalf of SAT and AWO Alliance, we welcome you to this live webinar series on advances in casting and splinting. For the participants who are joining us for the first time, a quick introduction about SAT and AWO Alliance. SAT was formerly known to most of the orthopedic surgeons as BSN Medical. SAT is a global hygiene and health company headquartered at Stockholm, Sweden, and has presence over 150 countries. While AWO Alliance is a developmental non-profit organization dedicated to improving the care of the injured in low and middle income countries. This is the third program in a series of live webcasts scheduled every Saturday from 1 p.m. to 2 p.m. over the next 2 months. And the topic for today's session is latest advances in casting and focus rigidity casting, which is a novel technique in managing distal radius fracture. We are privileged to welcome Mr. Samuel A. Brown, who is a keynote speaker for this session. Mr. Samuel A. Brown is a global medical trainer and an experienced orthopedic technologist from US. And joining the speaker, we have distinguished panelists chairing the session. I would like to welcome Dr. Jawahar Jetwa, who is a consultant orthopedic surgeon from AMC MAT Medical College, Ahmedabad. I would also like to welcome Dr. Dilshan Manidasa, who is a consultant orthopedic surgeon from National Hospital of Sri Lanka. We are privileged to have Dr. Jim Harrison, who is a consultant trauma and orthopedic surgeon from National Health Service, Chester, UK. In today's program, we would start out with a speaker session. It would be followed by a case discussion by Dr. Jawahar Jetwa, and that would be followed by Q&A session. So I would request all the participants to post their questions in the question box below the video screen, and all the questions will be addressed during the Q&A session. With this, I would request Mr. Samuel Brown to start the session. Over to you, Mr. Samuel Brown.
Konnichiwa. Welcome. Hello for everybody from Tokyo. What we're going to start off with is I'm going to talk about the history of casting and where we got to where we are today. So first of all, I'm going to talk about plaster of Paris. Plaster of Paris was invented in the 1800s. Some say it goes back further than that, but the first documented medical use of it was in the 1800s. It suits the purpose for immobilization, but it has many disadvantages to it. An advantage to it is cheap, very cheap, but disadvantages is it cracks, it takes a long time to set, and it's definitely can't allowed to be exposed to water once it's set. Next slide, please. Next. Okay, so this is a overall of the three generations. The second generation was fiberglass. It was established in the late 1970s. It's a very rigid casting material. It's light. It sets very fast. However, it has very sharp edges, and there's a high chance of it cracking. The reason why a fiberglass cast will crack, especially like a short leg weight-bearing cast, is it has the glass component in it, and glass breaks. So if you put weight on it, that's going to eventually break. And then our third generation of casting is our polyester. Polyester was invented in the 2000s. And it kind of solves all the problems. It's light. It dries just as fast as fiberglass. However, it's got a polyester component to it. So consider it. So think of fiberglass. It's got the glass component, but the polyester is like a plastic bottle. So it's not going to crack under weight loads. The radiolucency of it is extremely high. It's about 95% radiolucent, so it's almost invisible on X-ray. And you use it the same techniques as you would use with your fiberglass. Cost over the long term. POP is cheap. It's as cheap as it can get, but you get what you pay for. The fiberglass is going to be considerably more than the plaster of Paris. but the fiberglass is more durable. And the polyester is going to be almost the same price as fiberglass. It depends on the market and the country. That depends on the import tariffs, et cetera, et cetera. But you have a far more superior product in the polyester. Okay, next slide. So in the first visual, what you can see is the polyester has a 3D stretch. You can mold it and shape it in ways that you can't do with fiberglass. You can see on the red cast on the slide number 1, that's with polyester. And look at the white on the posterior aspect of the humerus, I think that is. You can see the gapping, and that's with fiberglass. So you can see in slide number 2, it perfectly conforms to the calcaneus, also to the olecranon. So you don't have any areas that are not covered or that are gapped over. And then you can see the X-ray with the radiolucency of it. And also with the polyester, which we will demonstrate in the video coming up, you can see that you can cut it very easily. With my techniques, I cut it with the scissors. So that takes a lot of anxiety out of the process of cutting a cast off. I came up with my techniques because I'm a big bald guy, and I would walk in to take off a cast with a pediatric patient, and they're scared because I'm holding this saw. And, there's a lot of apprehension with that. So my techniques that I developed is so I can use scissors to cut it off to lessen the anxiety of the patient. Okay, next slide. So let's talk about cast padding. First of all, everybody uses cotton and stockinette. Cotton stockinette, cotton padding. The disadvantages of that is, number one, it smells. Why does it smell? The patient's going to sweat in the cast. The cast is going to absorb that sweat, and that sweat is going to turn into bacteria. And so bacteria is what we are actually smelling inside the cast. So we have an unhealthy environment inside the cast. I know here in Japan, where I live, Japanese doctors, they traditionally change the cast every 10 to 14 days because that's how Japanese are obsessed with cleanliness. So that becomes a big cost product to the Japanese government because it's a national healthcare system here. So whereas in America, we would do one cast for 5 to 6 weeks, they're using 3 casts over that same amount of time. And casts aren't cheap. They're not expensive as surgery, but they're definitely not free. So you have the itching, the smell, the limitation in their daily activities, and patient hygiene. Okay, so next slide, please. So what SD has created is Delta Dry. It's a polyester cast padding and stockinette. And what it does is water repellent. So what happens is the patient can wash the cast, they can get a shower, they can continue on like their normal daily activities. So what it does is you use it just like you would your cotton stockinette and your cotton padding. Same techniques, there's nothing different about it whatsoever. And when the patient gets a shower, what they do is they let the water drain out of the cast. And then once the water has stopped dripping, I suggest the patient get a towel and try to dry the cast as much as possible with a towel. Now, the inside of the cast is still going to be wet, but the patient's body temperature is going to dry the inside of the cast. It's going to evaporate any kind of moisture that's inside the cast. Now, that's going to depend on how long that is going to do is going to depend on their environment. If you're in a humid environment like India, particularly, it's going to take a while. It could be 1 hour to 1 hour and 15 minutes. If you're in a dry climate, it could take 45 minutes. I've done experiments myself, and this is speaking from a bald-headed guy. I used a hairdryer on it. Strange apparatus to me. And I used a hairdryer on it, and with the heat, was a little bit too much for me. It was a little bit too hot for me. But if you just use the non-heat option, just air dry it, I got it dry in 10 minutes. So it's a very fast way of drying the cast. Now, how fast it dries also depends on how many layers you use. So you'll see in my demonstration on the video next that I try to use as few layers as possible. One thing I see globally is people use too much cast padding. So the more cast padding you use, the less immobilization you get, per se. Traditionally in Japan, they'll use 2 or 3 rolls of cotton just for a distal radius fracture. That's way too much padding. When you use too much padding, what that does is the arm can piston inside the cast, and you have micro movements. And we want in immobilization, not micro movements. Okay, next slide. So yeah, I probably already talked about some of this stuff. Other things I will highlight about this is if we see down on the bottom left with a lower leg cast, you see how the patient's leg is positioned there. That's what they want to do when they come out of the shower. They want to flex their knee probably 15 or 20 degrees and let the water drip out until the drip stops. The reason being is water can accumulate around the calcaneus, and if the water stays there, it's going to create tissue problems. Also, the same thing with a long arm cast. You want them to hold their arm down until the water completely stops dripping out. Okay, next slide. Okay, so what I'm going to talk about next is we're going to show, I guess we're going to talk about types of fractures. I guess I'm sure everybody here is aware of how to classify all these fractures. Oh, another thing I want to say about Delta Dry is I tend to not use it with elderly patients because elderly patients kind of forget those key things to help the cast. And you can have complications with that. Now, if you have an elderly patient that has in-home care, then you can talk to the caregiver about the instructions on how to use it. So next slide. This is a standard algorithm for distal radius treatments. I'm sure everybody here already knows this. Conservative versus surgical. A lot of doctors are very quick on doing surgical. There's been studies that show there's no long-term difference in the mobility or functional quality of life versus conservative and surgical. Now that depends on the type of fracture, obviously. Non-displayed, a lot of people they jump to the gun and they just go ahead and do surgery. Well, it's not necessary in all the cases. Next. So what I'm going to talk about, or the video we're going to show, is my technique we developed. It's called focused rigidity casting. So basically the concept is put multiple layers of the fiberglass or polyester where you need it the most. And with the polyester, you can see on the dorsal side, I only keep 2 or 3 layers. Now, it says less rigid, but it's still stiff. But on the volar aspect, you can see there's 4 or 5 layers, and it's super stiff there. But what this allows me to do, it allows me to, once you get above 3 layers, you need a cast saw to remove the cast. But if you keep it 2 to 3 layers, you can use scissors to remove the cast. Next. So next we're going to jump into a video demonstration of this technique that I just talked about. So here I've already applied the Delta Dry stockinette and the Delta Dry padding. Now here I'm going to measure a slab for the volar aspect. I want it to go from the palmar crease to about mid shaft. And once I measure my slab, I'm going to make a 3-layer slab. Next, I'm going to submerge it into water. By the way, I always use room temperature water, never use hot water. I'm going to place it on the volar aspect. And I place it at an angle, kind of a diagonal angle. I think that helps bring support to the cast as we pronate and supinate. And next I'm going to start proximal and work my way down distal. And I'm using the polyester cast tape because it gives you the angles that you just can't get with any fiberglass cast tape. So important here, you see I'm going to angle down at almost a 45-degree angle. And in 3 revolutions, I'm going to be at the distal end of the cast. I'm going to make a cut for the web space. Now we're going to flip our edges of the stockinette. And I always double flip the stockinette, even though I didn't do it in this video. I usually double flip it to give more padding in the web space. And then I repeat the first step. Again, angle down. It's very important. That's something there you can't do with fiberglass. So 3 revolutions and we're at the distal aspect of the cast. We cut another web space cut. We come back around to the volar aspect and I cut. And now we're finished. Most people would continue to roll until the roll is finished. But again, I want to keep it very thin on the dorsal aspect. If I would continue rolling, I could not use the scissors to cut it off. So now we got about 5 or 6 layers on the volar and about 2 or 3 layers on the dorsal aspect. So now I mold. Now I'm just laminating my edges. But now I mold. Always mold with your palms. I want to try to make that as flat as possible. And again, with the polyester, you can mold like no other product. The dry time is about the same as fiberglass as well. And then one other mold that I do, once I get the forearm flat, is I will wet my thumb. And I think we'll see this in a minute. I wet my thumb and I mold the palm. And this molds better than POP. So with that combination of Delta Dry stockinette, Delta Dry padding, and the polyester tape, there's no reason to change the cast at all. So very cost effective in that regard. Now, people ask about the skin quality after using this. I've seen many patients that's had this cast on for 6 weeks, and their skin quality looks very good. Typically, you have the dry, scaly, itchy skin, but not with this, because they're able to get water inside the cast. They can put soap inside the cast, and so the skin responds to it very good. Okay, thank you.
Thank you, Mr. Samuel Brown.
Thank you.
Before I seek comments from the panelists, I would request Dr. Dilshan Munidasa to talk about the different reduction methods in distal radius fracture management. Over to you, Dr. Munidasa.
Hi everyone, having listened to the casting new method, I would like to present some orthopedic aspects of how do we select patient for the casting and not selecting for surgical option, and the methods that we employ in obtaining pain relief during reduction. For this presentation, I would like to talk on how do we select patients and whether to manipulate or not, and type of anesthesia, the reduction method, and the immobilization and rehabilitation will be discussed by the other panelists. So there are two groups of things that we consider when we are discussing about the patient with distal radial fracture: the patient factor and the factors related to the fracture configuration. Basically, the patient's age and hand dominance, profession, comorbidities, activity level, all related to the patient's factors. I would say at the outset, none of these are absolute. You can go to a younger patient for a conservative or non-operative method, depending on other factors, domination of other factors. When we talk about the more anatomical factors about the fracture configuration, we talk about the radial inclination, radial height, dorsal angulation, the ulnar variance, amount of comminution, whether it's intra-articular or extra-articular fracture, and whether there is a large ulnar styloid fracture where you think that the radio-ulnar joint is unstable. So generally the fracture happens after a fall on outstretched hand, that is, we call it swoosh. And this would result in multiple fractures, multiple deformities of the distal radial fracture. So first of all, before we identifying the deformity, we must know what is the normalcy. Generally, the radial styloid is higher than the ulnar head, and the articular surface of the radial radius is at an angle of about 21 to 25 degrees to the line of the radius. And also there is tilt of about 11 degrees polarly in relation to the long axis of the radius, and the ulna is generally at the level or little lower than the radial articular surface of the lunate articular surface. If you see any of those parameters are disturbed, then you consider about bringing it to alignment. So if these are in align, we can go ahead with casting for non-operative management without any reduction. So generally, if I show you this example of distal radial fracture, you can see the radial height is lower than it is the radial articular surface is lower than the ulnar head, and it is angulated. In the lateral image, you can see it is angulated dorsally and it is shifted dorsally. So when we consider of this reduction of this fracture, we need to know what configuration is in the fracture. Generally, there are about 5 or 6 deformities in the distal radial fracture. Firstly, it is impacted, that is, it is proximally driven, and it is laterally displaced and it can angulated laterally, and it is dorsally displaced and angulated, and also the fragment is supinated. So when we consider about the reduction, we have to reverse all of these deformities. Let's see how we do this during actual case. So we have a big case for conservative management, that is non-operative management in the distal radial fracture. That's why I said at the beginning that none of these factors are absolute. So in the recent meta-analysis, they have shown that there was no difference in complication rate between the treatment groups, whatever the age group is. In this, it has also shown us that in a group of patients older than 60 years, there's medium term dash show in the subgroup of studies that only has shown that there's no difference in the medium term outcome. And also it has been shown that operative treatment resulted in higher complication in this older age group. So therefore, we actually speaking, the casting is very important because we have a strong case for the non-operative management of distal radial fracture. So there are certain relatively unsuitable patients. These are highly uncommunicated fractures, intra-articular fracture, open fracture for you need some wound debridement, fractures with carpal instability, that is the intra-articular fracture with volar displacement and dorsal, and young active patient with unacceptable displacement you consider not suitable for non-operative method. And again, unstable fracture after reduction. You think it's going to get displaced in the cast, then you straight away go ahead with the operative reduction. So in the management, we have 3 R's, 3 stages, that is reduction and reduction maintenance and rehabilitation. In the reduction, it happens in 3 phases. You have seen in the previous demonstration. It is we have to reduce the fracture beforehand and then apply the cast, and then you mold the cast with the reduction and to then maintain with the casting. So for when you decide on certain fractures, you do not manipulate, then you straight away go ahead and do casting if those angles are in anatomical, near anatomical levels. In others, you need to do reduction, for which you need some procedural anesthesia, for which you need certain things, the gloves, the syringes and needles, and the solution that we use is about 8 to 10 cc of 1 or 2% of lignocaine. So this is how we do that. We first clean with, we can do it in the outpatient department with iodine. Then you can feel the fracture with your thumb. You can feel the step. So then you inject the solution of lignocaine at an angle. The fracture is generally angled at 30 degrees towards the long axis of the radius, and you aspirate and see whether you are in the actual hematoma. You will see altered blood coming into the syringe, or you can sometimes see fatty solution, which is sort of fat that is in the fracture site. And then you can inject the solution and wait for about 5 minutes, and then you do the reduction first by reversing the deformities that I have just described. First by disimpaction, by applying traction, and then push the fragment with your thumb, and that will correct both the dorsal angulation and the dorsal tilt. And then you do the radial correction by pressing from the radial side of the stereostyloid. And when you do, you always do pronation to correct the pronation. So let us see in clinical case how we do this, and this is how we do the correction of the dorsal tilt and dorsal displacement in the first picture. And when the assistant is pronated, the segment is reduced in pronation. And then you place your thumb on the radial side and push from that side. That will correct the radial tilt and radial displacement. And you can do that Also, that without any assistance also, if you have the finger trap, you hang it on the finger strap, and without any assistance you can do, and you can do the manipulation casting single-handed in this method. Whether you do a dorsal radial slab or the full cast determines your stability that you feel during the reduction. If it is minimally displaced fracture, is stable after reduction, and less comminuted, you would like to put a dorsal radial slab. The cast is suitable for less stable, and there's minimal swelling. And if it is comminuted, then it is much more beneficial to have a full cast. I think rest of the things will be discussed with the other panelists during that. My presentation is that just over.
Thank you, Dr. Munidasa. Now I would request the rest of the panel to comment on the two speaker sessions. Starting with Dr. Jawahar Jetwa. Any comments on the speaker session?
Yes, Sam has shown very good technique, and I learned a couple of things when I have viewed that in detail. My query is regarding that word carcinogenic dust particles. It's something very alarming. And how come FDA has approved when it is carcinogenic? But one of my friends had a clear-cut understanding of the allergy whenever he used to cut this fiberglass plaster. Somebody else is cutting, and then the dust comes on and he gets allergy. So that is something which was, it is known, but looking at it as a carcinogenic is something a little bit more. And yes, Munidas has very, very clearly stated about the dorsal tilt fractures, how to reduce. And I think there are two additions which I like to make. One is the word called milking. Milking means when you give a traction, then with the palm you try to catch hold the fracture area and then ask the assistant to wobble it anteroposteriorly. So it is something like milking. So minor comminuted fractures will go into that, and you will have a better thereafter disimpaction and reducing all the fragments. And it is very important that the initial displacement is very important. If the initial displacement is too much, it's going to give you trouble. So you'll have to put it into reverse direction, the whole cast. If the initial displacement is not much, then in those cases you can give not in an extreme pronation or extreme volar flexion, maybe in a reasonable volar flexion. But otherwise, it's a good method he has narrated. Thank you.
Thank you, Dr. Jetwa. Now I would request Dr. Jim Harrison to share his comments on the speaker session.
Yes, thanks very much, and greetings to everybody. Yes, lovely presentations, and nice to see this. I think we do notice quite a swing back towards more non-operative care of distal radius fractures. I think this presentation is quite in keeping with this. I'm working in the UK now, but previously worked for 11 years in Malawi and Central Africa. But even in the UK and the high-income country setting, we've had quite recently the draft study, DRAFT, from Matt Costa. And then that was initially a comparison between distal radial locking plates and K-wires. And then now they're going on to not even having the K-wires, but doing pure non-operative care. And more we're seeing that in terms of the functional outcomes and the quality of life, the non-operative approaches can give really good outcomes with fewer complications. We may talk a bit later, but the elderly and the osteoporotic bone obviously behaves different from the young patients. And we have to target our aims in the non-operative care towards the expectation of how a softer bone will behave in a cast. And maybe we'll come back to that later. Thank you.
Thank you, Dr. Harrison. Now we move on to the next segment of the program, which is a clinical case discussion. So I request Dr. Jetwa to start the discussion.
So I'm sharing my presentation. Hi, everybody. So I'm very thankful to the organizers, SCT, for giving me this opportunity to talk on a case presentation. Now, the case is about a male 62-year-old who has just fallen from a two-wheeler. He reported within an hour. It's a close injury, right hand. He is diabetic, hypertensive, but under very good control. And he himself is a chartered accountant. And this is his X-ray when he arrived. And before I ask the panelists what can be done, a little bit more information is that this X-ray was taken somewhere else before he reached to my clinic. He had minimum pain. And he was very calmly waiting in my waiting room for his turn. And when he presented to me, he said, I do not want operation. And he said that he has selected me for my seniority and skill of non-operative management. Now, with this background, let me know from the panelists what can be offered to this patient. Yes, can anybody give any comment?
I would speak on this. This is a 60-year-old male, and considering his age that I, as discussed in my presentation, patient fracture comes into the first place, and then regarding the displacement, there is intra-articular. This is the intra-articular fracture, and really speaking, you go ahead for surgical correction in an otherwise younger patient. The fracture itself is about less than 2 millimeter displaced in the AP film, and there is volar displacement. There is definitely a case for a surgical reduction in a younger patient. Then other factors come into picture: the age, the dominance of the hand, and activity level, and with other patient's expectations. Then you can make a decision. I think a clinical scenario with the patient, you have to have a discussion with the patient. Which way would you like to manage this fracture by you?
Right. So, Jim, can you give some comment on?
Yes, thank you. I agree with the comments made. So it's an intra-articular fracture, but there's also some volar or palmar displacement. The intra-articular step looks to be more an opening, a separation than a step as such, and may actually be relatively forgiving. I think if he wants non-surgical treatment, I think it's possible, and it may give a very good outcome. I would obviously in the manipulation try to reduce the palmar displacement. That's going to be important. The positioning of the wrist to maintain it. If you go by the old Charnley principles of his conservative treatment of fractures, you would actually then flex the wrist slightly to try to avoid redisplacement of that. And then there's even the question whether you'd use an above elbow cast in supination for a short time. And I know that we tend to try to avoid immobilizing the elbow, but in a fairly active sort of middle-aged patient, he probably would tolerate about 3 weeks with an above elbow cast, and you might get slightly better control. So I would consider that option with him. And then obviously the molding of the cast around that to try to retain the radiocarpal alignment so he doesn't get that redisplacement in the palmar direction. I think that's important. And congruity of the distal radio-ulnar joint I would expect to be quite good in this fracture, and that's very important, and that's going to be a good marker of potential success in non-surgical treatment. Yes.
Sam, would you like to say anything? You are muted.
Okay.
Yes.
Can you hear me?
Yes. Yes.
The only thing I was going to say that since it's intra-articular, I mean, you want to try to preserve that articular surface as much as you can for osteoarthritis in the future. And if it was a younger person, I would certainly say, yes, surgery would probably be warranted for that. But since he's an older gentleman, and number one, he said he didn't want to have surgery. I mean, you can't make the patient do what they don't want to do. So that's all I have to say about that.
So now here we are having a patient who said, I do not want operation. And if you are doing surgery, if complication occurs, he said, I told you not to operate. Secondly, if we do not operate, then we need to know what can happen. Thirdly, all over the world, in any meeting I go, they always say what the patient wants. I think it is an inappropriate question. All patient wants to go to Olympic and get gold medal. It is the surgeon who has to say that I cannot give more than this. It's a limitation of surgeon rather than expectation of the patients. But anyway, so what is more required is that I have to convince him that better is a surgery. So what I did is naturally I tried to get the CT scan. So with the CT scan, I also know how much exactly is the displacement, and he also would know that this is the whole scenario. But in this X-ray, yes, we know that it is a distal and radial fracture. It is intra-articular. He's having a volar mild subluxation, and a good part which Jim has said is an intact distal ulna and distal radioulnar joint. That's very important. So what I did, I thought that what could be my next steps, because he doesn't want operation. So I thought, let us investigate further, classify fracture, refer textbook, refer literature, counsel the patient, reduce and apply slab, check and apply circular cast, remove cast by 5 to 6 weeks, and absolutely I need to be on to after treatment for the recovery. Because something which is done against my will, so I have to be very careful, and every time I have to remind the patient that this is something which can go wrong. So as far as the CT scan is concerned, these are the selected views wherein I can see at the level of scaphoid, there is not much intra-articular problem, but at the level of lunate, a little over there is some dorsal displacement of the small fragments. And the book says 2 mm, 3 mm, 1 mm, 4 mm. It's very difficult to measure actually. It's very difficult to know exactly what is the step or gap inclusive of cartilages. But anyway, it is what book says. So I also got another transverse sections view at the proximal level, at the little distal level, and at the joint level. And I thought it is not very bad as far as the intra-articular part is concerned. Sort of a very big dye punch is also not there. To explain patient, now to explain the patient, this is very important to have a 3D CT. 3D CT shows, a very dramatic view. So this is a volar view, this is a medial lateral view, and this is a posterior view. And I also was convinced that since he doesn't want, I should try without operation. So what we did is we again tried to explain to the patient the radiology report. And the radiology, usually they don't mention exact gap. Some of them are recently now showing. And he very clearly mentioned distal ulna as a normal. So that is also very important for documentation. So then I went for the classification. So from this X-ray, I found out from my mobile app that the best classification is 2R3B3, and that is something called Walder-Ream or reverse Barton or Goran-Smith 2 type, all this. And then I checked the textbook, because it is something which I'm not doing routinely and I'm doing in this case. So textbook says that cast treatment for such patient with this classification is for undisplaced or minimally displaced, low demand patients, exclude unstable patterns, obtain a good reduction, meticulous cast technique is very much needed, and do not immobilize in extreme of position because it is not fully reduced. There are going to be some congestion in the volar side with the carpal tunnel syndrome type of problems. And we need to have careful follow-ups. That was from the textbook. And I found from the literature a study of 23 cases where it was they were treated without operation, and they had followed up to 70 months. Only 11 were having a satisfactory outcome. And out of 11, 5 were without subluxation, but 6 were with subluxation. And there also they got a satisfactory outcome. So paper says quality of reduction influence outcome a lot. And articular steps should be less than 2 mm after reduction. Now these are some of the things. With this basic idea, with explanation, I counsel the patient for possible outcomes, for possible common complication, for possible rare complications. I counsel and explain everything before slab application, before circular cast application, and during rehabilitation. So many conversation is required when you go for a conservative line of treatment. So what I did, I just gave a volar slab, cock-up slab for about 4 days, and I got the reduction from the volar side at the distal end and from the dorsal side, little proximal in the forearm region. And I was very happy that he could attend his grandchild birthday party with the plaster on. So it was a very comfortable one, because from the beginning I said he had minimal pain. So it was fairly stable on his first presentation. So you can look at this plaster with that. He's holding his grandchild and he is very happy. So then I did follow up for circular cast, which was removed after 5 weeks. Home active exercise instructed, follow up for 4 months. And at that time, patient and me both were satisfied. So what I mean by satisfaction, this is the original fracture at the end of 4 years. This is how the nature has given a fantastic remodeling, a very good healing, a minimal of the intra-articular gap. And then I tried to check it with the normal side. And so I compared it with the normal. How is the modeling occurring? I think my voice may be a little bit slow. Now it will get back. Okay. So this is the way we can compare and we can study the cases which are not treated by operations. And this is what I call is a satisfactory outcome: the fracture, the union, and full pronation, full supination, full dorsiflexion, full palmar flexion. So friends, what we have learned from this case is investigate fully even if you are not going to operate. Exclude unstable variety. Counsel well and inform the consent even if you are not operating. It's not only that when operation is required, you go for a consent. These are the cases where you have to be very clear with the patient. Achieve best possible reduction. Apply best cast technique. Remove cast in time. Because longer the cast, we have not operated the patient, there are n number of complications like syndrome and dystrophy and many other things. So remove it in time and do careful checks during rehabilitation. So this is what I learned from this particular case. I hope I could share some of the important points of conservative management with the plaster technique. So I thank you very much, SCT, for this opportunity. Thank you.
Thank you, Dr. Jitwar. With this, we come to the end of the second part of the session. So we move on to the last segment of the webinar, which is Q&A session. And the first question is from a comment from Dr. Thedis Longo, who is also one of the faculty in this webinar series. According to him, one of the tricks of molding is to apply a very wet band for around 2 minutes, because that will give a strong stability to the overall cast technique. Any comments from Samuel Brown?
So what was the question again?
Dr. Thedis Longo says one of the tricks of molding is to apply a very wet band for around 2 minutes and then remove it. This might give higher stability to the cast.
Yes, I have another trick that I use too. You know what plastic wrap is? Like what you would use to cover a dish before you put it in your refrigerator? Like some people call it saran wrap, plastic wrap. If you take plastic wrap right when you finish applying and you wrap the cast with the plastic wrap and then you mold, that gives us far superior molding ability. And also the plastic wrap, you can't even see where your layers were. It really adheres everything to each other. But yeah, I agree with his technique, but that's my technique if I have it available to.
There is a non-effect which is called onion effect. Onion effect means the layers of the plaster, they are not fused together because of the lack of moisture. So I agree that this type of adding moisture, I usually use a spray bottle to spray and sprinkle some water over there. And the problem was with the fiberglass, because fiberglass was difficult to unwind. It was a little bit sticky. So if you drop into the water, then it becomes too difficult to stretch it back and then to roll it. Sometimes the plaster itself is very tight. But with the polyester, it unrolls very freely and smoothly. So in those cases, you can even spray this bottle in between. You can see that the whole plaster is moist well. But yes, compared to plaster of Paris, these type of plaster do not require too much of water. Once they are exposed for some time, within 10 or 20 minutes at the most, they set very well. It's a good idea to add moisture like this. Yes.
So the next question is directed to Dr. Jim Harrison. The question is, does conservative casting methods violate AO principles? He wants to know whether muscle atrophy is reversible after casting.
I got the first question, which was about AO principles. I didn't quite get the second part.
The second part is he wants to know whether the muscle atrophy is reversible or not after casting method.
Muscle atrophy, yeah. So firstly, in terms of AO principles, well, the heart of the AO principle is to restore function, isn't it? So it's in terms of reduction, appropriate stability, maintaining the biology, and restoring function. And I think that can be done with casting techniques, especially around the distal radius, where we normally only leave the cast on for 5 weeks, and you can do quite a lot of exercises in the cast while it's on. So it's very important to train patients about finger exercises. We're all very aware that the MCPJs here are the particular ones that stiffen. So patients tend to do this, don't they? But we need them to do that. And so our cast must allow them to actually flex the MCPJ. So movement is very important, but casting techniques can allow movement. You can also work on the rotation movement in the cast, and for most of the fractures that we treat non-surgically, after 2 to 3 weeks, we'll be disciplining and training the patients to start doing supination and pronation in the cast. And I think it's very important to do that. Otherwise, it's very difficult afterwards. I always tell them if they can't supinate, they won't be able to get their change in the shop, so they won't be able to put their hand out to receive their money. And once you put it to them like that, they usually understand that they need to learn to supinate again. So that's my tip on that. In terms of the muscle atrophy, yes, muscles do atrophy even in 5 weeks, and with some partial exercises and movement, you still lose something, but this should be restored afterwards. And I would put it to you that even with an operative technique, you really don't save a lot of time above that in terms of when you can really restore those movements and those muscle functions. So yes, I'm happy to treat a lot of these injuries non-surgically.
I have a comment on this. Can I give a comment?
Sure, Dr. Jacob. Yes.
One thing is very good that you give in a functional position so that except the abductors of the small muscles of the palm, all muscles can virtually, can go for exercise to minimize the disease atrophy. And sometimes it happens that in India we say namaste and we put the hands like this. This is a perfect 30-degree dorsiflexion. So in a cock-up position, there are a couple of good at ease position for the plaster. And in that ease position, which is the most functional, favorable position, and that should be, I think, taken care of. Yes.
So the next question is addressed to Dr. Dilshan Munidasa. The question is, what is the idea behind injecting xylocaine at the fracture site to assess supination or pronation?
The idea of giving xylocaine to the hematoma is to anesthetize the periosteum and the nerve fibers so that the manipulation can be done without causing much pain. Some surgeons add to it some sedation as well, but to get the patient's pain relief during manipulation, you need to have some kind of pain relief. I think the name given here is the procedural anesthesia. That will not only correct the pronation, supination, that will the surgeon can correct all 5 deformities: the dorsal angulation, dorsal displacement, radial angulation displacements, as well as supination. All can be corrected.
Okay, thank you, Dr. Munidasa. The next question is addressed to Dr. Jawahar Jethwa. The question is about the operative management of distal radius fracture. If a surgeon chooses plating or K-wiring and he wants to do a post-operative immobilization, whether he should go for an above elbow splint or below elbow splint?
Well, naturally it depends on the, your confidence in fixation. If the fixation is extraordinary, no slab. If the fixation is little bit, you feel like that long incision has been taken and some soft tissue rest is required, you give cock-up slab. And in those cases where it is very osteoporotic, where you are not able to completely disimpact the fracture, when you know that there is some more combination which is going to be unstable, and patient is also so elderly, less likely to cooperate so well, in those cases better to give above elbow slab. So it all depends on the final feel of the surgeon, that how much was the fixation, and accordingly you can have a type of immobilization. But yes, in those cases where it is something where you do not want to open up and you want to do percutaneous spinning, in those cases it's better to give above elbow slab for at least 2 to 3 weeks. Yes.
Okay. Any comments from the rest of the panel?
May I ask Samuel?
Yes.
In casting technique, you haven't used extra padding for the bone prominences like conventionally that we do. Is it a necessity here in your casting with polyester, or you can just avoid adding extra padding for the radial and ulnar styloids?
Yes. To tell you the truth, when I moved to Japan, we didn't have we had the Delta cast stockinette, but we didn't have the Delta Cast padding. It just hadn't been approved by the government to be sold here. So I had to change my methods to only using stockinette. And that's the way I still teach it here in Japan, because it's just not available here. And so what I do to address it, and I only use one layer of stockinette. Now, doctors look at me like I'm crazy when I do that, but I think, again, getting back to what I said earlier, the less padding you use, the better fixation you have. So what I teach Japanese doctors is put on one layer of stockinette, and then on any bony prominences, I'll cut another little piece of stockinette, and I'll either double it over and just put it on that area. So any bony prominences. So if I'm doing a short leg cast, I'll use whatever I measure that I need. I will double that and then pull it into itself, so it's automatically 2 layers. Once I apply it, I'll check the medial-lateral malleolus, and if it still feels like it could use an extra padding, I'll just cut an extra little piece just for that one area, though. But I always tell people to check the bony prominences, especially with females. They usually have a huge ulnar styloid. Then definitely you want to just put a couple of layers on there just for safety. It's better to be safe than sorry.
So regarding his question, Munidasa's question, I would like to ask Jim that when you say that you allow supination and pronation inside the cast, and as Sam said that there is going to be a sometimes very prominent styloid process region of the ulna in some of the patients, particularly thin patients. Now, do you soft change of padding or some more pressure sore when you allow such movements?
Yes, it's a good question, isn't it? I think the feeling I would say is that most patients won't mobilize beyond the tolerances of their discomfort. So we would use a normally padded cast with some padding over the head of the ulna and the ulnar styloid. But of course, you're right, when you go into pronation, the ulnar head becomes more prominent, doesn't it? And but most patients won't go beyond pain for that. I think actually a lot of them struggle with getting supination, and so often I would emphasize the supination movements as well to them.
Yes, by the way, a very good trick to get good supination is to ask the patient to washing their face. It is maximum supination with pressure. And that you're massaging the face and pressure, somehow or the other, this is very good exercise. Maybe from 3rd month to 6 months, they get the final supination which they wanted. So that is what I have learned from the patient. It's a good trick. Thank you.
Thank you, panelists. I think in the interest of time, we will not be able to take further questions. So before I conclude the program, I would like to hear closing comments from the panelists, starting with Mr. Samuel Brown.
Well, I want to thank everybody for tuning in today. This is a unique event that SCD is putting on. Again, I look at this as the 3rd generation of casting. POP was the first, fiberglass was the second, and polyester is the future. And if you've got a patient and you're worried about hygiene, then definitely go with the Delta Dry stockinette. There's nothing else out there on the market like it. And I've totally switched over to the polyester. I don't use anything but that from now on. It just gives me everything I need to do, and it's very unique material to work with. And I appreciate everybody tuning in. Thank you very much.
Okay. Dr. Jetwa, any closing comments from your end?
Yes, it was a very good session. And as I said, I learned from Sam. But I would just remind viewers that it was a model. It was not a patient. He was not anesthetized. So naturally, we have to be a little more careful and gentle in applying such plaster. But it is a good way when you are going for a conservative management. And Manidas has said very clearly that it can be done with intrafocal anesthesia as an outdoor treatment. I think it's a very good session and good learning. Thank you.
Okay. Dr. Munida, sir?
Thank you for giving me this opportunity to speak on this webinar. So I thank SCT for introducing, particularly Mr. Sam, this technique of new polyester cast is still not available in our country. So we have a good look of it, and I think it's a feasible option for a distal radial cast for a patient who is going to manage conservative. And also I must thank all the other panelists who made very good contribution and very good presentations. And I also learned a lot from them, and thank you very much for all the panelists.
Dr. Harrison, closing comments from your end?
Thank you. I hope all the participants enjoyed it. I've certainly enjoyed it, and I've learned things, and I think that's maybe the important thing. We all have more to learn, and I think the better our understanding of the injuries, the patients, and the techniques and the equipment available to us, then the better we can harness those things together for the good of our patients. So we don't all have fancy casting things available, but we can all do better with what we have by increasing our understanding. And I think that's a really important principle. Thank you.
Okay. So with this, we come to the end of the program. I would like to thank all the speakers, panelists, and all the participants for making this session a great learning experience. And I would request the participants to share their feedback either in the question box below the screen, or they can reach out to the WhatsApp number and the email ID mentioned on the screen page. If any of your colleagues or team members could not access this webinar, please inform them that the respective web links will be available and active for the next 1 month period, so they can access the recorded webinar. And before we take leave, an important announcement about the next webinar. The next webinar is scheduled on 6th June from 1 p.m. to 2 p.m. And the topic for the session is how to prevent and manage complications associated with casting. And for this session, we have the speaker, Dr. Jawahar Jetwa from Ahmedabad, Dr. Devashish Barik from Nagpur. And we also have panelists from Bangladesh, Dr. Amjad Hussain, and we have Dr. Klaus Dressing from Germany. So we hope to see you all in the next webinar for this session. Thank you very much and stay safe.
Thank you.
Thank you.
Thank you. Thank you.